I've been asked to talk on pediatric head neck condition. It's a huge topic, so clearly I can't cover everything. I will, you'll see I'll skim through some slides and focus on certain conditions which I feel are clinically more relevant to you guys, and also certain things which easily get missed. Okay, so broadly we can classify pediatric neck masses into congenital, infectious, and neoplastic. Congenital neck masses form the bulk of the neck masses that we see in our clinics in children. And there's a long list of conditions or congenital masses that present in the clinics. But I'll be mainly focusing on the top four because those are the more common ones: thyroglossal cysts, branchial cleft cysts, lymphangiomas, Haemangiomas, and I'll skim through the rest. So let's make a start. So I'm sure you know what a cyst, what a sinus, and fistula is, so I'm not going to dwell on that. So let's start. Thyroglossal duct cyst. This is the most common congenital midline mass. So you will end up seeing them wherever you are as a elective presentation in the clinic or as a presentation acutely with an infection. To start off, it's an asymptomatic mass, roughly at the level of hyoid or slightly below. And it's a clinical diagnosis. The clinical diagnosis meaning this is a midline lump which elevates with tongue protrusion and also on swallowing. That's how you differentiate it from other lumps or other midline lumps. So it's fairly equal in boys and girls. The average age is around 5 years of age. 90% of these lesions are midline. Some of them are lateral to one side. And again, majority of these, 75%, are pre-hyoid or around the hyoid. Yes, of course, they can be above and below, and that's where your embryology comes in. So these lesions or thyroglossal cysts can literally be anywhere from the level of foramen cecum width, that's where the thyroid gland starts, and down to the neck. So anywhere around this tract of the thyroid gland, we can have these thyroglossal cysts, but the most common site is around the thyroid. So another thing which I'd like to point out here is when you see or make a clinical diagnosis of thyroglossal duct cyst, you've got to think in your own mind that this is not an ectopic thyroid tissue. Again, be aware, if in an ectopic thyroid tissue, that could be the only thyroid tissue and also high risk of hypothyroidism. So once you made your clinical diagnosis, you will send the child for investigation, and that simply means ultrasound scan to be done by a head and neck radiology consultant. And the ultrasound is not going to give me a diagnosis of thyroglossal duct cyst. That's a clinical diagnosis. Ultrasound is mainly done to check that the thyroid gland is in a normal position. And, very rarely, if, for example, you don't find the ultrasound scan on the normal thyroid, then you're thinking in terms of a thyroid scan to check where exactly is the thyroid tissue in this child. So once you've done all this, the treatment ultimately is surgical. Simple excision is almost not done anymore because it has a very high reoccurrence risk. So it's the mainstay of treatment is cyst trunks procedure, which simply means removing the thyroglossal duct cyst along with the hyoid bone and the muscles around. So cyst trunks procedure has a 10% reoccurrence risk. So more or less now in my practice, what I do is a modified cyst trunks procedure. And the key thing with thyroglossal access is do not trace the tract. It's a wide excision. Um, Essentially, as I describe it to my trainees, just think it as a level 6 nectar section, including the hyoid body and the cyst. So after you've raised the skin flaps and exposed the neck structures, you will first identify the thyroid isthmus, and that's where your excision starts. So essentially, from the level of thyroid isthmus, you will excise the medial strap muscles, so to say 1 centimeter on each side, right up to the level of hyoid body. Then you excise the body of hyoid and continue with your excision and get a cone of tongue-based muscle. So that's a modified cyst trunks procedure with good results. And that's what's recommended these days. And that's the same child before and after a surgical procedure with a neat scar and healed nicely. Moving on to the other big topic, which is branchial cleft anomalies. So again, the embryology comes in. I'm sure you're aware there are 6 branchial arches that are being developed with 5 pouches and 5 clefts. And ultimately, all these branchial anomalies are somehow related with these branchial clefts. So overall, the branchial cleft anomalies are the second most common head neck congenital lesions seen in children after thyroglossal cyst. There are various theories proposed, but it is essentially incomplete obliteration of these branchial clefts and pouches during the embryogenesis. They are quite common. They are almost 20% of cervical masses in children are some kind of branchial anomalies. Rarely in 1% cases, they can be bilateral. And there is no right or left predilection with these. So the most common branchial anomalies is the second cleft lesions, which account for 95% cases. First cleft are rare, but easily missed. So I will spend some time on those. They account for about 1 to 4%. And third and fourth anomalies are extremely rare. So essentially along the sternocleidomastoid border, the first arch anomalies are somewhere around here, around the angle of jaw, second arch along the interior border of sternocleidomastoid, and third arch quite low down. So this is a key thing I have to say, that essentially they are along the interior border of sternocleidomastoid. First arch anomalies around here along the angle of jaw, further down. Second arch anomalies anywhere around here, and third arch being further down. So I will spend some time on first branchial cleft anomalies. Even though they're rare, they're easily missed. So they're easily missed, especially if you're not thinking about it. So I'll just give you a little bit of a background of this child. So this is a child who was referred to me from my local hospital. And this is, a 3-year-old girl who kept coming to the A&E and the ENT clinics with recurrent infections around the earlobe. That was her only symptom. Gets an infection, given some antibiotics, settles down, and she's back. Every month, she kept coming back with these lesions. You can see almost permanent skin discoloration. And at some point, somebody thought that, oh, this might be a first cleft anomaly, and hence got referred to me. So these first cleft anomalies are divided into work classification, work type 1, being only ectodermal in origin, and there is the tract can be, or the lump can be superficial to the facial nerve. This is another child. This is more classical, has not had any infection. You can see a tiny fistula there, and you can also see a swelling along the floor of the ear canal. And work type 2 has ectodermal as well as mesodermal components, meaning skin and the cartilage. Or the easy way to remember is it's a duplicated ear canal. Almost if you imagine extending from there to there will be a duplicated ear canal under the skin. And again, the tract for these work type 2 can pass medial or lateral to the facial nerves. So once you made a diagnosis, or at least thought about it clinically, it's a matter of investigation. Ultrasound scan is the first investigation, easy to do, and done by a good head neck radiologist, gives you a lot of information. So that's will be the first line investigation, doesn't need any anesthetic. And then once you have your diagnosis confirmed or a provisional confirmation, then you can send the child for an MRI scan for more detailed surgical planning, I would call it. Of course, for younger children, the MRI scan will need a general anesthetic, and hence it's a second line investigation. And in an MRI scan, really what I am looking for is this anomaly or the sinus tract superficial or deep to the facial nerve? So that really helps me with the surgical planning. And again, with these conditions, ultimately the treatment will be surgical, and it will be a parotid type approach with a modified Blair incision. So this is another child on my operating table. You can see a fistula there, sort of a bony, not a bony, swelling in the floor of the ear canal. So lazy S incision, elevate the flaps, and that's your swelling in front of you, which you dissect. This was luckily superficial to the facial nerve. You dissect the swelling, being aware of the facial nerve. And if you open up the swelling, you can actually clearly see a duplicated ear canal with the skin, the hair follicle. You actually can see hair and the cartilage, and hence no wonder if there's a skin and cartilage in a pocket underneath the skin, at some point this will get infected, and ultimately you will need to excise it completely. And once you've done a complete excision, it's a good end result. So the key message I have to give to you guys is, if you see a repeated infection, if you see any fistula or a swelling in the floor of the ear canal, think of a first branchial anomaly. Unless you think about it, you will miss it, and they get easily missed. And once you think about it, or you have suspicion, then refer it to the tertiary centers for further investigations and management. Second cleft anomalies, very, very common, very easy to diagnose, so it's not complicated at all. Usually it is some kind of a fistula along the interior border of sternocleidomastoid, and it can be anywhere along the interior border of sternocleidomastoid. The tract goes deep to the platysma and runs between the carotid arteries, and generally it's superficial to the hypoglossal and glossopharyngeal nerves. So again here, the treatment is surgical. Wherever your fistula is, there's an elliptical incision around the sinus opening, and you carefully dissect close to the sinus tract. So this tract and the thyroglossal duct tract is very different. The thyroglossal duct has branches, so it needs a wide excision, while these second branchial cleft tracts, they do not have any branches, and you stay close to the tract and keep dissecting it right to the top. And yeah, rarely they go up to the tonsil area. Generally, most of the times I'm able to manage with one incision, but yeah, rarely you need to do two incision or a step ladder incision. So quite common and easy to excise. Third and fourth arch anomalies are extremely rare, and essentially there's some sinus arises in the hypopharynx, piriform sinus areas, and it runs between the carotid arteries, vagus nerve, and ends around or in the thyroid gland. Third ones, this is all theoretical actually, you can't dissect these, is superior to the superior laryngeal nerve, while the fourth branchial pouch anomalies are caudal to the superior laryngeal nerve. So again, with these ones, you've got to think about it. If somebody or a child is presenting to you with a reoccurrent neck infections or a reoccurrent thyroiditis or thyroid abscess, so think about a fourth branchial pouch anomalies. Having said that, these are extremely rare. So investigation-wise, yes, MRI scan of the neck reported by a good head neck radiology is really, really helpful. And once I've done an MRI scan, it confirms or gives me a hint or a suspicion. The second investigation I would do is a microlaryngeal bronchoscopy. And ultimately, with these lesions, also you're going to need some kind of surgical procedure. The tract for these third and fourth anomalies are very, very complicated, and there are some limited reports on a formal surgical excision, but that's not very popular because it's a very extensive surgery. More or less, what we do these days is diathermy to the internal openings, just sealing off the tract, and that seems to do the job. I'll just show you a picture. So that's a microlaryngeal bronchoscopy view. This child actually presented with a swelling. So this was a swelling which was aspirated, and on a close-up view, you can see a fistula right at the depth of the bottom end of the piriform fossa, which essentially you use any kind of diathermy. I just use a SMD needle and just essentially burn it to seal it off, and that seems to do the job. Okay, so we'll move on to the third conditions, which is lymphatic malformations. Again, I'll say fairly common, so you will end up seeing these conditions as well at some point during your clinical practice. So again, these are congenital lesions. They are dilated lymph channels which are somehow not connected to the lymphatic system. Various classifications, just to keep it simple. Type 1s are below the mylohyoid and type 2 are above the mylohyoid. Various terms that are used, cystic hygromas being the most common one. So type 1s are quite common. They are or can be in the anterior and posterior triangle. Again, cystic variety is most common. If you request a CT scan, which is easy, quick to do, there's a ring-like margin enhancement. Again, luckily, these type 1s do not infiltrate into the surrounding tissues, but of course, they can be bleeding in the cyst, which can lead to airway obstruction. And this is a classical one in the anterior triangle, a good one to do with excellent surgical results. This is another child that I was involved in. This is more posterior triangle, a huge swelling. I think this child was only maybe 3-4 months of age when they first presented to me. send them for MRI scan, and a huge swelling involving the whole of posterior triangle as well as the anterior triangle by the time it came to surgery. But again, good results surgically. These are some surgical photographs of the same child, and you can see it's there has been some bleeding, and hence it looks bluish in appearance. Large swelling, and ultimately good end results. This is another interesting one, and that's why I put it. This child came to me with just almost a smallish, soft swelling in the parotid region, which was just intermittently going up and down, no other problems. And sent him for a MRI scan, and this was a large lymphatic malformation in the deep lobe of parotid, and again, a parotid approach, had to dissect out the facial nerve, and ultimately good end results after the full surgical excisions. This is another child, extremely large swelling. Of course, these get picked up on antenatal scans, was picked up, had a tracheostomy, and of course, the large lymphatic malformation was excised with good results. Okay, so moving on. Type 2 lymphatic malformations luckily are rare, but they're very difficult to treat as well. Usually in and around the oral cavity, lips, tongues. There's no ring enhancement here on the scans. These are much smaller lymphatic channels, but depending on anatomically where they're placed, they can be associated with airway obstructions. Management, of course, depends on what type of lesion it is, type 1 or 2, where it is. So hence, scans come in very handy for you to plan whether this is just in the neck, where exactly in the neck, is there a mediastinal extension, is it extending into the floor of the mouth, and so on. And then ultimately, you have to plan along with the parents what what treatment, I should say, route you'd like to take. Yes, surgical excision is one of the main treatments, I should say, especially for the type 1s. Type 2s are difficult. They're difficult because nothing works really. So yes, you can laser them off, you can coblate them. Sclerosing agents certainly are not very effective in type 2s. They have no planes, and they lead to prolonged wound drainage. Okay, so have a drink of water. So moving on to another reasonably big topic, hemangiomas and vascular anomalies in the head and neck. Just some definition, because it is quite important that you clinically are able to differentiate whether it's a hemangioma or is it a vascular malformation. So hemangiomas are essentially hamartomas. They are disorganized, non-neoplastic overgrowth of cell types. Hemangiomas, they have rapid growth in early infancy and ultimately slowly regress. And hemangiomas are almost never present at birth. On the other hand, vascular malformations, they are just abnormalities of the vascular development. They are present at birth. They grow with the child and will never disappear. And you can divide these vascular malformation to slow flow and fast flow. So again, to reinforce, so hemangiomas are not present at birth. They usually start appearing roughly 6-8 weeks of age as a red spot, and much more common in girls than boys. They have a proliferative phase from 6 months to 12 months of age, and ultimately involute or go away on their own, but that can be up to 5-8 years of age. While on the other hand, vascular malformations are present at birth and they will grow proportionally with the child. So that's the key slide for you to be able to differentiate these conditions clinically. So histologically, again, vascular malformations are dilated blood vessels, while hemangiomas are rapidly dividing endothelial cells. So they can have hematological and skeletal issues if these are large lesions, so be aware. So hemangiomas actually are very, very common. Rather, they are the most common benign lesion in infancy. So 10% kids will have some kind of hemangioma. And as I said before, they usually appear around 6 weeks of age. They can be just a small lesion somewhere, 80% of cases, 20% they can be multiple. And head neck is the most common site for hemangiomas. They can be superficial, just involving dermis, or they can be subcutaneous. So, something like this, other than watching it, you don't really need to do anything. It's not causing any trouble other than, a little bit of a cosmetic issue, but ultimately it's going to go away. So these hemangiomas, or the treatment becomes essential if they're causing some kind of obstruction. And some kind of obstruction, I really mean either they're causing some visual issues, or they are in the visual axis, or they're causing some airway issues, meaning subglottic hemangiomas. They can also, if they're big and in their proliferative phase, can lead to bleeding, ulceration, and as I said, rare conditions can lead to congestive heart failure or coagulopathies. So you have to manage them depending on the individual child and the location and the size of the hemangioma. So uncomplicated cases, not causing any functional issues, you can simply wait and watch after you made your diagnosis, and of course confirmed it with either an ultrasound or an MRI scan, and just explain to the parents the natural history of the disease and review them in the clinic now and again. But of course, if they're causing any issues, then you need to treat them. And the treatment again is medical or surgical. Medically, steroids were the mainstay of treatment many years ago. It still is a relevant treatment. And the key thing with steroids is you should start them on a high dose, prednisolone, 2 to 3 milligrams per kilogram per day. And they should respond within 7 days. So review them within a week or so. If they've responded, great. If they've not responded, then think something different. They're not going to respond. Propranolol, of course, came in vogue maybe now 10 years ago, and it's, as you know, a beta blocker does have significant side effects as well, and the usual dose is 1 to 2 milligrams per kilogram per day. Of course, in certain conditions or certain anatomical position, surgical excision is also an option on the table. So just, this is the guidelines I wrote during my fellowship years, because propranolol at that time was quite new. So you should be aware of this. This has been published in JLO 10 years ago. So pre-treatment, anybody you're thinking in terms of starting on propranolol, of course, take a detailed history and examination, specifically any history of heart disease, asthma, such like things. Blood test, full blood count, kidney functions, liver functions, thyroid functions, ECG, echoes, definitely involve pediatricians. And when you're starting anybody on propranolol, they need to be admitted, even if just for 2-3 hours on day case ward. You take a baseline pulse and blood pressure. You start on a very low dose, 1 milligram per kilogram per day in 3 divided doses. And when you start the dose in the hospital, you monitor their blood pressure every 30 minutes for the first 2 hours, just to make sure they're not having any significant hypotension. And just keep on a low dose for a week, and then again they get admitted, and you raise it to increase the dose to 2 milligrams per kilogram per day. And again, they're monitored for 2-3 hours with the blood pressure monitoring. And once everything is settled, they're sent away home, but they need to get a weekly blood pressure check done for the duration of the treatment, which can be anywhere between 12 to 18 months. So it's a long and significant treatment. If you're giving this for a subglottic hemangioma, you need to start the treatment and assess for a response at 6 weeks to see it's actually working, because not all, it's not 100% treatment, not all hemangiomas respond to propranolol, and then repeat endoscopy. So this is just some pictures illustrating that. A large hemangioma, so these are vocal cords there, and that's a classical location in the subglottis on the left side, large hemangioma, and you start propranolol 6 weeks later, you can see it has started shrinking, and another roughly 6 months later, and nearly 1 year later. So they need serial monitoring. Surgical excision for subglottic hemangiomas, it's an option on the table. It's a good option. And again, just to illustrate to you, vocal cords, the subglottic hemangioma, it's an open surgical excision, meaning midline laryngofissure approach. That's a thyroid cartilage, cricoid tracheal rings, temporal tracheostomy, midline laryngofissure, and it actually shells out like a pea. It's a good operation, one-off, and with excellent results. I also published a series of surgical excision cases done at GOS during my fellowship years with very good results. So once the hemangioma is excised, the child sent to ICU just for 4 or 5 days, and it's you scope them a few weeks later, it really heals very well. So it's a good option and should be offered to the parents as well. Okay, so capillary malformations are just abnormal dilated capillaries, or what's called port wine stains, and usually you see them in the trigeminal nerve distribution. Rare, we don't see them. These patients generally get seen in the dermatology clinic, but the main comment I'll make is any one you see with these capillary or other hemangiomas, be aware that they can have an intracranial vascular malformation, so do send them for an MRI scan of the brain to rule out any intracranial hemangiomas or any vascular malformations. So for these capillary malformations, again, management, if it is not bothering them, yeah, they don't necessarily need any treatment. Dermatologists can offer them laser therapy and very rarely surgical excision if they ask you. Okay, I'll spend a few minutes on venous malformations. So these are essentially dilated vascular channels. They are compressible clinically, non-pulsatile masses. The treatment, again, if it is not causing any troubles, you can leave them. Sclerotherapy is actually an excellent option here. And if it is doable, then yes, surgery is an option on the table. So this is just a child with a significant venous malformation in the airway. And you can see the epiglottis is fine with a lot of venous engorgement in the supraglottis. So clearly this is not surgically excisable. They are not going to respond to steroids or propranolol for that matter. And really the only option is going to be sclerotherapy, and further down the airway is pretty clear. So arteriovenous malformations, pretty rare. We don't really see many. They're generally intracranial, but can be external. And depending on where it is, and the throbbing pain or sudden tinnitus, bruise. So as I said before, yes, of course, you need an MRI scan for confirmation and the extent. If they're asymptomatic, you don't necessarily need to do anything for these AV malformations. And of course, you do an angiography and selective embolizations for these conditions. Teratomas can happen anywhere in the body, very rare. Yeah, ultimately, it's a matter of making a diagnosis and surgically excising. I'll spend a couple of minutes on a dermoid cyst. They get easily confused with thyroglossal duct cysts. As I said before, these are also midline, but these will certainly not move with tongue protrusion and possibly also not on swallowing. So be aware they do get misdiagnosed as thyroglossal duct cyst. But the treatment is actually very easy. For these, the treatment is simple surgical excision. Of course, you investigate by an ultrasound scan. I just want to put these couple of pictures. So for these are rare condition, but be aware. So this is a child who presented to me literally with a small, hardly visible opening in the midline with just a drop of watery fluid leaking. So that's it. So so anywhere in the midline, if you see a fistula, be aware of dermoids. So another child, all he had was this little fistula. Do you see? Yes, you confirm your diagnosis by an MRI scan, and ultimately they're going to need a surgical excision. Extremely rare, so I'm going to skip through this. I would like to spend 2-3 minutes on this one because this is something, it's a spot diagnosis, but similarly easily missed. And it is a complete misnomer. So sternocleidomastoid tumor of infancy, or congenital torticollis or wry neck. So the typical story is maybe a prolonged labor or a difficult delivery, and the child is just keeping his neck to one side. It's not in pain or anything. And generally they present within a month or so of being born. And generally these children will either present to the GPs or pediatricians And on palpation, it's quite a firm, though painless mass in the sternocleidomastoid, and because it's a firm mass, the GPs and the pediatricians start worrying about it, that, oh, is this some kind of a tumor? And again, it's about history, examination. It's just, or the pathogenesis is some trauma or some extension of the neck, a hematoma in the sternomastoid muscle, and that hematoma now has been replaced by a fibrous tissue. So yes, you give them a clinical diagnosis and reassure the parents that this is going to ultimately go away. Yes, get the diagnosis confirmed by an ultrasound scan of the neck, and yes, certainly send them for some physiotherapy of the neck. Otherwise, the scarring, and they'll end up with long-term torticollis. Right, moving on, infectious masses. I'm going to skip through majority of this. So again, a long list of infectious masses. Most common is viral lymph nodes, bacterial abscesses, inflammation in the salivary glands, and further down the list, tuberculosis. So viral lymphadenopathy, very, very common. You and me don't even end up seeing majority of these. They just end up going to the GPs who observe them or give them some treatment if needed, and they go away. But of course, if somebody gets referred to you, large swellings and not disappearing, of course, send them for investigation, and do think in terms of immunodeficiency. This is what you commonly get seen in the hospital setting, because they've start off with a lymph node infection, and then separates large abscess, which of course needs surgical drainage. I'm going to skip through these. I'm going to spend a little time on this because this is another condition, though it is, or it should be, a spot diagnosis. It gets easily missed because, one, it's rare, and second, unless you think about it, or unless you have that at the back of your head, you will miss it. And moreover, these don't present to you initially. They will initially present to the GPs or the pediatricians, but be aware. So this is classically, generally, a child, anywhere between 2 years to 7, 8 years of age, healthy child, absolutely healthy, not in any pain, no temperature, but just has this very gradual, insidious onset discoloration of the skin, and few lumps, almost like lymph node type lump, again classically in this region, around the angle of the jaw, over the parotid region, and on the submandibular region. So this is your classical appearance, and it's a spot diagnosis in an otherwise well child of an atypical mycobacterial infection. And generally, by the time you get called to see them, the pediatricians would have done all their investigations. They've sent swabs, cultures, and they're getting nowhere, and hence you get called. So this is a spot diagnosis which you should be aware of. There was this randomized control trial published in Clinical Otolaryngology, which was a good, precise study, and I'll just put it up here. So they compared surgical treatment only with antibiotic treatment only. Excellent results with surgical treatment, 96% cure rate, and with antibiotics only, yes, 66%. Again, the natural history of these is, even if you do nothing, it will ultimately regress, but that then it leaves a weepy wound for months and months, and not so good looking scars. So antibiotic treatment, It's a combination treatment. Some kind of a macrolide, azithromycin, clarithromycin, has to be given for 2 to 3 months. You can add in some antitubercular treatment, but of course, you need to involve the pediatricians for that. Really, the best option is a combination treatment. And again, it's for the parents that need a lot of reassurance, because it's not going to suddenly disappear, any of the treatment options you choose. So this is again a classical child. You can see is in theater. What I want to illustrate is have a facial nerve monitoring, because you are at risk of causing injuries to these nerves, even though your dissection is not going to be deep here. And it's just a matter of what I will call tidying up, elliptical incision around the lesions, and easily remove what you can easily remove and curate. Remember, this is not cancer. It's just a matter of tidying up and giving them a good incision, ultimately a good scar at the end of it. And it heals nicely. You, of course, will cover it up with some clarithromycin. Okay, I'm going to skip through this. I've been hearing about this, the corona virus related also. It's a multi-system vasculitis. Kids are quite unwell, and generally in the intensive care unit. Okay, nearly at the end. I'm not going to go into details for the neoplasms, but of course, for all these benign conditions that you see in children, they are rare. And yeah, you can generalize, yes, make a clinical diagnosis in them with scans, and treat accordingly. Again, extremely rare malignant conditions, be aware, again, make a diagnosis, and they will need to be referred to an oncology center, MDTs, and the treatment. And that's all. I think we're getting towards the end of it. Yeah, I just want to say this. I teach on this MCH ENT program at the Canterbury University in Kent. The applications are open for this year. And of course, next year, the course usually starts in September. So I'll highly recommend to any of ENT trainers or specialists who are looking for a higher degree in ENT. And that's that.
Thank you so much, Prof. That was
some questions.
Talk as always. Yeah, so we have some questions. Can I just check? So you described type 1 and type 2 lymphatic malformations. Are they the same as macrocystic and micro?
Essentially, yes. Yeah, essentially anything below mylohad or anything below the floor of mouth generally is macrocystic type 1 surgery. Anything above that is microcystic type 2, difficult to treat. That's in summary what it is.
Okay, great. And sorry if I missed this. You talked about surgical excision for subglottic hemangioma. Yep. Did you say you cut through the cricoid?
So yes, I can take you back through that. So because I normally talk more in details on that one. Yes, so midline horizontal neck incision, elevate the flaps, expose your airway, temporary tracheostomy, and then that way you're out of the way from the anesthetist, you've given them an airway. Once you've done that, so yes, midline incision in the neck. So that's the thyroid cartilage, then the cricoid, and first 1 or 2 tracheal rings. So midline partial laryngeal fissure, meaning half of the thyroid, cricoid, tracheal rings, and you open them up with these stay sutures, and that's your lump, which is here, which is essentially in front of you, and it's as simple as grabbing it with a forceps and excising it with a fine scissors, and believe me, it doesn't bleed at all.
I was going to ask, does this cause subglottic stenosis?
No, no. So coming to that. So good question. So once you've excised the, so to say, lump on the lesion here, you are, of course, you can see here, it's the posterior cricoid plate, which now has got no mucosa because you've excised that. Because you have, so to say, destabilized the airway, and hence you will send this child. So at the end of the operation, you'll get a tube from the top, a nasal tube through there. This comes out and you close it up. So you close it up over an endotracheal tube just for 4 or 5 days for things to settle down. And this, believe me, within a week or two, this full mucosalization happens. Mm-hmm. So when you see this child 6 weeks endoscopy, you can actually see nothing, not even a scar. It just looks like a normal airway. So it's an excellent treatment, if you personally ask me, rather than being on propranolol for 2 years with the significant side effects that it comes with.
Mm-hmm. Mm-hmm. Okay, fantastic. Okay, so other questions are, if you haven't, how often do you find an incidental finding of a thyroglossal cyst, and does it need to be removed, or do you watch and wait to see if it's causing any problem?
Okay, so very good question. So because I still do a little bit of adult work, my approach in adults and kids is different. Okay. In a child, for example, you picked up in a child who's 2 or 5, or for that matter, even 10. I actually, of course, you have to have a discussion with the parents and offer to them, this is what it is. It's nothing dangerous. Explain to them what it is, why it is. But in children, generally, I would recommend surgery because they've got many years to go and they are at a higher risk of infections. Similarly, if I've picked up an 80-year-old who has had an incidental thyroglossal duct cyst picked up, no, not for an 80-year-old I'm going to offer them surgery. And I've come across these in 80-year-olds also who have told them what it is. You made a diagnosis. They've not had any infections for the last 80 years, another 10 years of their life. So yes, in children, generally, I would personally recommend surgery, but of course, you leave it to the parents at the end. But yes, so I wouldn't hesitate. I wouldn't sit on it and wait and watch. I just get on and do it. Because I would rather operate on this child before he gets an infection. It's a much neater surgical field than going into for a surgery once they've had few infections. It just fiber optic and stuck up and all that.
Okay, yeah, great, thank you. Another question is, how can you differentiate between a first branchial cyst and a preauricular sinus?
Oh, that's very easy. I mean, I think I didn't again go into the details of time. Issues. There we are. That's your answer. So the preauricular is literally this area, preauricular, while the first arch ones are generally in this area, so around the earlobe and the angle of the mouth. So that's the difference. It's a location. And preauricular are generally just here, I mean, rather more even higher up. So yeah, around the angle of the jaw. And of course, if you're not sure, then that's fine. That's where the scans come in. Just sending for a basic ultrasound scan is good enough. But yeah, that's a differentiating point, the location, the history. So first arch are usually around here.
Okay, thank you. The next question is, do you biopsy a subglottic hemangioma?
The answer is no, you never. Yeah,
So,
again, I can, it's a good question though, but let me, so again, I'll go to the picture because it's easier to explain on a picture. So for example, this one, this is pretty obvious. Well, say this one, this is, once you go in with your telescope and you see it, and you think in a minute, well, that's pretty obvious answer. All you do is take a blunt instrument and compress it. You just press it, and this gets squashed. And the minute you release the pressure, it just fill it up. So that's your diagnosis. You don't take a biopsy.
Did you say?
Sorry?
You need to do any imaging after the procedure?
Not necessarily no is the answer. If it is, I mentioned that, and that's a good question as well. When there is a hemangioma somewhere in the head neck region, you should not be missing an intracranial AV or any kind of malformation. So scan is needed really, actually, yes, electively at some point, more an MRI of the brain. Not for this. Yes, if I've, for example, and I have you picked up a parotid hemangioma, then yes, I'd initially do an ultrasound and then an MRI scan for confirmation, MRI scan of the brain also, and then yes, not necessarily need to do anything or any treatment, just watch them and just reassure them this is what it is, that's a natural history, and ultimately it's going to disappear.
Okay, thank you. Next question is, can you explain the mechanism of action for propranolol in subglottic?
Nobody knows, so I can't. I can give you a lot of theories, and the theories are essentially it works on endothelial growth factors. That's it. That's as close as it gets to a theory. So there is, for the hemangiomas, there is this endothelial growth factor, which essentially gets the hemangiomas to become proliferative. So yes, the theory is the propranolol somewhere, more as a side effect, if you want to call it, works on this endothelial growth factor. Mm-hmm. The answer is nobody knows, really, for sure.
And another question on propranolol is, how do you stop it? Do you stop it immediately?
Yeah, okay. So the treatment is individualized to the patient. So, and that's what you follow. Generally, my advice, and again, to you or anybody, is don't take it in your hands. We are not medics, okay? The treatment generally should be given by the pediatricians or dermatologists, because they are, they do this, so to say, on a regular basis. They know what, how to manage beta blockers and their side effects. We don't. So this protocol I put up so that you are aware, but yeah, I would not say to you, go away and tomorrow you start the treatment, because it's a significant medical drug with significant side effect. So yes, you do all these investigations, very gradually start the treatment, and then look at the response in 6 weeks' time. If it is something obvious externally, then you can see it, or photo documentation. Or if it is an airway hemangioma, then yes, you have to scope them. Mm-hmm. Because the first thing you got to check at 6 weeks, and same for steroids also. You see, none of these treatments are 100% treatments. So first you have to see, is the child responding? So that's what you will do at 6 weeks and check the response. If you say, oh yes, it's responding, then you will then repeat the endoscopy or next one at 3 months interval, and then serial endoscopies. And that's where your natural history of the disease comes in now. Okay, so now this kind of a child, large hemangioma, you scope them at 6 weeks, you say, oh yes, this is responding, let's carry on. And then you check again, and then you check again. So you're just simply buying time. I mentioned in my original slide about treatment, steroids, propranolol, surgical excision. For subglottic hemangiomas, if, for example, this one, if it was a circular, circumferential hemangioma, then, you hope that propranolol will work. But if propranolol does not work, then really your only option is a tracheostomy. You then just simply bypass that hemangioma, because the natural history is that in approximately 18 to 24 months, this will shrink away. So yes, even if, for example, this kid had a circumferential hemangioma, worst case scenario, does not respond to propranolol, does not respond to steroid, you can't excise it surgically, because that will leave you with a subglottic stenosis. Then all you do is bypass it, give them a safe airway, give them a tracheostomy. You will do the same. You will still serially endoscopy to see how the hemangioma is doing. And ultimately, you will decide once the hemangioma has shrunk on its own or with propranolol, then you think in terms of, do I decannulate? Or in this case, for propranolol, you will gradually stop the propranolol. But that doesn't mean after that you just discharge them. You still have to observe them. So yeah, minimum the treatment is between 12 to 18 months if you look at the papers and practice. And you will still scope them, of course, after you stop propranolol, just to make sure that it's not coming back.
Yeah, absolutely. Okay, fantastic. And how can you differentiate between a simple subglottic cyst and hemangioma
Very easy. Just by looking at it. I haven't got pictures of subglottic cysts here, but in future we can do talks on laryngology. Subglottic cysts are actually, again, easy to diagnose and easy to treat. Like anywhere in the body, it's just a thin-walled cyst, which you literally can puncture very, very easily. But this is more a bulky lesion. This is not a cystic by appearance.
Okay, it's slightly more irregular.
Yeah, and this is compressible. Cysts, yes, they can be compressible. They're not completely despair on. If you apply persistent pressure, say for 30, 40 seconds, this will disappear or significantly shrink. A cyst will not. It'll wobble here and there, but it's not going to disappear.
Okay, great. Moving on to the thyroglossal cysts, what's your personal preference, a cyst shrunk or a modified cyst shrunk?
I've already said so. So my, I gave up doing normal cyst shrunks ages ago. So the answer is modified cyst shrunk. That's what should be done and is done these days with excellent results. And again, the key is this slide. Horizontal incision, raise the flaps, define your anatomy, go right. So, even if the cyst is right up there, so, I mean, for people or my registrars who worked with me, it's the treatment is exactly same that I do in any thyroglossal system, wherever it is. You have to excise right from the bottom, right to the top. Because, for example, your cyst is here, but embryologically, the tract is going right to the thyroidisthmus. You start from here, you leave that tract behind. It is possible you might have a reoccurrence there. Then you're in a bigger situation. So I would rather do one proper operation. Yes, it sounds extensive for something tiny as here, this one, and you're doing a level 6 next dissection, but that's the proper treatment. Do it one-off, do it big, and it'll give you good results. Yes, start right at the level of thyroidisthmus at the bottom and excise all these strap muscles. Keep going till you hit the hyoid bone. Excise the body of the hyoid and keep going, literally a cone of the tongue base. Yes, the main, yes, in addition to your standard risk, the main uh, risk I warn the patient, which is what I commonly see, is seroma formation, because you have left such a large, so to say, a potential space. Yes, you'll have a drain for initial day or so, but because there's so much potential space, there will be some oozing, and more or less, almost I will say 50% or more kids will develop some seroma. So these kids, I personally review them at a week and then on a weekly basis just to make sure they're not and it's not a big deal. If you warn the parents that there can be some fluid collection which I might need to just aspirate in the clinic. As far as you warn the patient, it doesn't come as a surprise to them. That's what I'd really warn them about: a seroma or a fluid collection. And yes, there are a few kids who have to aspirate a few times in the clinic, but then ultimately it settles down. Yes, that's the downside of doing a extensive procedure, but touch wood, I haven't had any reoccurrences since started doing this extensive.
So that 10% recurrence rate.
That's for a standard cyst rounds. Modified, it's it should be less than 5%.
Okay.
Really, if you've done a good job.
So next question is, do you request thyroid function tests for thyroglossal cysts? And would you expect thyroid to have abnormal thyroid function?
The short answer is no. I certainly do request an ultrasound, and that's not to give me a diagnosis. Ultrasound I would do to check that the normal thyroid gland is in position. As far as the normal thyroid gland is in position, I don't need to do anything. Now, the situation becomes complicated when you don't have a normal, but this is extremely rare. Then you start thinking, yes, at that point I'll think, oh yes, maybe I should do a thyroid. Maybe then I'm going to involve other people. Then this is, much more than just a surgical issue. So no, not for a routine. Yes, ultrasound to look at the normal thyroid gland.
Great. Would you mind showing your slide about the cat scratch disease? Only because
you had a kid.
You did have kids like that in Whitechapel, which is probably a classic, and it took a couple of months, unfortunately, to get.
Yeah, it is, again, because it's so rare, and we don't think. Neither do I expect you to think about it. And in a slide also I wrote ages ago. So. Essentially is very vague. The symptoms are very vague, bit of fever, bit of malaise, bit of lymph node, which, every other kid in Whitechapel has. So, but yes, I think it's not for you really to make a diagnosis. It's more a medical issue. Hence I, didn't spend too much time. It's not really, and you will not even, maybe now you will think about it because you've had a case, but I don't expect you to, hence I've focused on what I would like you guys to think on, like the atypical TB. So atypical microbacteria, pediatricians will never make a diagnosis, never. But you should walk into that ward and from a distance should make a spot diagnosis. But you will only make a spot diagnosis of atypical TB, provided you know for yourself. These kids will be sitting on PEDS ward. Now, yes, people are being, becoming a bit aware, but still, you will only in a place like Royal London. I'm just trying to think. 1 in 2 years is when you will see it. I still remember during my registrar years, I've only made one diagnosis, but because I was aware, when you're reading for the exam and all that, you walk into on a ward round on a referral and you make a spot diagnosis and just walk off. So that's how it should be. But you will only make a diagnosis provided you yourself know. Pediatricians will not make this diagnosis. So yeah, this is the kind of stuff you need to focus on, not in cat scratch.
Okay. Thank you so much.
Excellent. Thank you, Reshma, for this, and I hope you've learned something.